I haven't seen Liz in a while either, so when I saw them.
Yeah.
I think I'm.
Find something to do.
No, well then use it.
appointed CEO of Treasure Coast Community Health. Welcome,
Thank you.
Heather. Glad you're here, along with your team.
Madam Chair, before we begin, I just want to be clear. Normally, if we were voting on anything with Treasure Coast, I would recuse myself, but I don't believe we are.
No.
We will be doing something at the end after this presentation. There was some recommendations that staff made that I wanted to make sure that the trustees took a look at, if there's anything that we want to move forward with that recommendation. But it's not related to.
Well, I'll go
When we
with
get
the
to that,
advice
we
of council.
you can recuse yourself and
Right.
and leave. Right.
Like a combination today, the back lines of the shirt, feels good.
Yeah.
I'll be right back.
Find who it
Okay.
is. Tracy. Okay, there we go. Sorry about that. Someone unmuted.
Okay, all right, great.
All right, we'll
Welcome.
get started. Thank you.
Yes, thank you.
You wanna, I can introduce myself. I know I've introduced myself to you all before. I'm Heather Miranda. I'm the CEO of Treasure Coast Community Health. I've been with Treasure Coast for 4 years. I was the EVP for 3.5. I have a 28-year history with public and community health. I started my career as a registered dietitian in Los Angeles, California. I'm still a licensed dietitian. I don't have time to see patients at this point, but yeah, so my focus now at Treasure Coast is we are looking at all of our programs and services. We're doing a full review of everything. But what I will say is that my focus is on growing the organization, stabilizing the organization, and making sure everyone has access to care.
Hi, yeah, Warren Fuller. I am the interim CFO at Treasure Coast, helping out. I've been working with them since April of 25, doing different special projects, primarily financial related. If you may probably know, I worked at Indian River Memorial Hospital for over 20 years. I retired from there as CFO for Cleveland Clinic.
And hi, many of you might have seen me in the audience, but don't know me. I'm Mary Linterman, and I became the chair of TCCH in July of 2025. I'm a licensed professional engineer with a degree from Bucknell University. And my work life spans from working from a top international engineering firm to moving to Vermont, becoming a vice president of a construction management firm there, where I grew the firm from 19 million to 200 million in 10 years. So I understand strategy, I understand process. During this time, Vermont's a small state, so many of us get asked to serve on the boards. So I was asked to serve on 7 separate governor-appointed boards, mostly related to workforce development and economic development. And additionally, I volunteered and led many nonprofit boards, including a philanthropic health foundation. I want to thank you for inviting us today. And I have to tell you, I am so very excited about TCCH's future. But first I realized that, well, actually I'll pause. As a result of the experience I had, I do want to say that I've witnessed that smart strategy, strong process, and governance combined with engaged people really can catapult an organization. And I'm here to tell you that story today. By happenstance, I heard about TCCH in 2023. Following my sister's death from an aggressive cancer, I discovered that I could donate sterile medical equipment to TCCH pharmacy team. And it was there where I learned about the pediatric building. And with my construction background, I offered to help. Of course, they went like this. And became a board member. But since I've been involved with the design and the building of medical office buildings, in fact, several of them, I became a board member in November of 2023. So why am I excited about TCCH? Since November, there have been significant positive changes. Many of these changes were motivated by 3 expert volunteers who stepped up to help TCCH in the middle of November. First was Sheila Schweitzer. She is a TCCH Foundation board member now. She is recognized healthcare leader by Forbes magazine. She's a national healthcare technology expert with a focus on revenue cycle management and streamlining health system processes. The second is Chip Weissmiller, who is an entrepreneur that owned and operated several businesses. But what helped us is Chip performed over 12 company retained turnaround projects. And then there's Warren Filler, who you know, and we're proud. He joined the board, Vicky had asked him to join the board early in 2025, and he stepped down to help us and now being interim CFO. So we call this team the Strategic Advisors. We are very grateful for their support and talent. And together with Heather, Dr. Miranda, and Dr. Loretta Farrell, and myself, the Strategic Advisors reviewed TCCH's systems and processes. The Volunteers Advisors met separately and independently with staff to look at finance, operations, information technology, communications, and fundraising. The meetings resulted in identifying issues and opportunities. Staff welcomed being asked for their input. In fact, they became enthusiastic when they realized they had a voice in TCCH's future. So during this process, we identified cost savings and optimization throughout the organization that will save TCCH $2.5 million, while not impacting the quality of care for the patients. These initiatives include increased access to care. We've begun using predictive analytics to identify and reduce the number of people who don't show up for their appointment. And now with two-way texting, we contact our patients on the waiting list and increasing our provider productivity. Another initiative, expanding chronic care management. Our population is aging. And more residents are being cardiovascular disease, high blood pressure, and diabetes. These conditions can lead to death and disability in our community. So providing chronic care management, our patients can live longer and healthier lives while staying out of the emergency department. Initiative, realigning our workforce to meet our ever-changing needs of our patients. This includes moving providers to locations where they have more demand and reducing, largely through attrition, the number of providers where demand is less, and outsourcing certain functions, such as our call center. With our call center, we're able to expand hours and decrease our costs and high turnover of staff. Another initiative, optimizing our service locations to improve our patient experience. Like many other FQHCs, we've made the decision not to renew leases where there have been low foot traffic. This includes our central site, which closed in January of 25, and our Sebastian site, which will close in June. Services and providers will be relocated to centers that TCCH owns. Care will not be interrupted. Patients, patients will be able to follow their providers, and this ensures a consistency of familiar care. And in December, when our office lease expires, we will move the administrative team to our Oslo Pediatric Center and bring it closer to our patients. Our longer term vision is to build a collaborative community health campus on at the Oslo site. This includes a standalone 6,500 building, which is Shell is currently there right now. And we're going to use that for nonprofit partners to provide health-related services that our patients need. We anticipate sending out RFPs likely in about 2027. Another initiative, working with patients to qualify them for Medicaid and district funding and lower their out-of-pocket costs and increase the likelihood they'll receive regular care. Even with our sliding scale discount program, many patients are still not able to afford copay. So while many are eligible for Medicaid or the district support, we have found that they are either not aware of their options or lack the resources to register. Our health navigators will work with both patients to qualify for the services, which will both reduce patients' out-of-pocket costs and actually increase our reimbursement rates. Expanding access to pharmacies, our low-cost pharmacy, allows our patients to get and take medications consistently. Through the federal government's 340B program, TCCH can purchase medicine at significantly below retail price and pass those savings on to our patients. We have pharmacy centers that we own, and patients get prescriptions before they leave their appointment. For patients who are not able to come to the center, we pick up their prescriptions, we can mail them or deliver them. Today, I am so pleased to tell you that TCCH is in a much stronger position than it's been in quite a while. And now I'd like Warren to give you a little bit.
You
Oh,
have the clicker right there.
Okay.
All right.
And now Warren, you wanna.
License to operate this. but-
Okay, let me just try to get some of these little things out of the way.
I think,
Okay, oh, you're good.
yeah, okay.
It's all right, it looked different for me.
Yeah, this is just kind of, for everybody's benefit, this is the, you know, but we have 30,000 patients we treat, I mean, we're that's significant, and we. You know, compare that to the total population, 124,000 visits, 9,000 children, and then 6,187 insured. 54% of our patients are below poverty level. So it's a challenge, economically, and so you have to optimize. Prescription 91,000, and then $4 million in discount too. All right, so we thought we'd share some financial performance information with you. So what we have here is 2023 through projected 2026. So in 2023, our revenue is $35 million. 3.5 million of that was from the American Recovery Act, which is COVID. Okay. Expenses were 31 million, profit of 3.7 million. So the 3.5 of that American Recovery Act, when you take that out, it was really break even. Cash was $9.5 million. 2024, our revenue decreased by 3 million. It's, you know, the COVID money went away. Our expenses went up though, about $4.7 million. So what happened there? In an effort to improve access to care for our community, we added 21 providers. Okay. And then on top of that, we changed our EMR. So we went to Epic, and that added another $800,000 of expense. So that, you know, the revenue went down, the expenses went up. That translates into a $4 million loss. Okay, so you lose $4 million, your cash goes down $4 million. Fast forward to 25. The revenue went up slightly, 1.5 million, but it did not go up enough to support adding 21 providers. That's really the supply and demand were out of alignment at that point. So the expenses went up slightly. That's inflation, right? It went from 36 to 37. You know, inflation, you're going to see some of that, especially wage inflation in healthcare continues to be a challenge. So we lost $3.5 million last year. Cash went down to 1.2. It's, you know, the math, you lose money, you lose cash. So the next column is our projection for 26. So as Mary mentioned, we have $2.5 million of initiatives in the plan. At this point, we're hitting our plan. So 33 million of revenue versus expenses of 34. You can see that decrease of expenses. That's the 2 million we're talking about, right? And it's optimization. It's really, it's doing stuff, you know, leases is one of them, joining supply GPOs to reduce our supply costs, optimization of support services where you know, folks that are not direct patient care folks. We're optimizing some of that through attrition. People leave, we figure out, okay, how can we get this done with less people? Really what it comes down to. So we're projecting to lose $878,000. Cash, 1.9 million is projected. I will say, this is a point in time. The goal is really to break even by the end of the year. We're looking for another $1 million on top of the 2.5. I'm very confident we're going to achieve that. So the cash would actually end up at 3 million, which is 30 days cash on hand, which for FHQC is really pretty strong. It really is. We want to be at 60, but you know, one step at a time. But that's where we're at. So,
And then we have the next slide for.
yeah. I told you I was. Yes, there we go. So, and then this is just more, as I mentioned, we're on track for what we have in our plan for $2.5 million improvement. This is evidence of that. Okay, this is the cost per encounter. So from December of 25, our cost per encounter was $302. Okay. At the end of March, it was 250. That's a 17% improvement. So, and that's gonna continue to go down. We really get a lot of traction in July. July through December, we have a lot of initiatives that are gonna kick in just because of logistics. We can't do everything at one time. And I will mention that we did pass along these savings to the district in our 26-27 funding request.
I noticed that. I was gonna make comment on that. They are sharing that.
Yeah,
so
we're sharing.
Thank you.
Yes.
All right, so this is a pretty impressive turnaround and we're continuing to work on our initiatives. We welcome questions.
So you had said back in 2024, you had added new providers of about 21. And that was for demand of service, is that correct? Or you just, I guess, no, my question is, you added those 21. Have you decreased the number of providers? Yes, you have,
Yes.
but you're still managing, because I know there's greater demand.
Correct. Right now, we're still continuing to right size. We are, as folks, if we have somebody that's leaving, we're assessing whether we need to add a provider or not. Our dental area, Dr. Joe's here today, is booming. And so we have added providers there. But some of our other services, our pediatric services have not been as high, so we're not adding providers in those areas.
And I will add that even when we kind of complete this vision, we're still gonna have capacity for over 20,000 more visits.
Okay,
Yes, so we're not running at, 95% capacity. We're like 80, 85.
We're at
So there's
80%,
plenty
yeah.
of room to grow and take care of the patients. Get them in, so there is a wait list. And the other part is our wait list, what went down, how many people?
We
are
had
on the wait?
we had 2,000 on our dental wait list. We've actually completely worked that down. But the dental department has extremely high demand. Yeah.
Question?
Yeah, thank you, Madam Chair, Dr. Mackett speaking. I just wanna commend Warren and the strategy team for what they've done for optimization and turning the organization around. I won't speak to my experience in TCCH, but I will speak to my experience at Indian River Memorial Hospital and Cleveland Clinic. And I can tell you, you should have full confidence in Warren.
yeah.
Because believe me, running an independent, non-for-profit hospital, you really have to pay attention to expenses in addition to revenue, and Warren knows how to do this.
Thanks, Dr. Mack, for putting the pressure on.
And very good to have one.
Yeah.
But thank you, appreciate that. I say the same for him. We worked together for quite a few years. He's a star. I think I said call Dr. Mack when I.
Other questions?
Alan Jones, I just wanted to ask, how much of your revenues that you get come from the federal government? And is there any risk to that support?
Well, I'll start with that. We're very concerned about government funding right now because of just the uncertainty out there and the interest in changing things. So it's significant. I would say probably at least 60%, at least, is either Medicare, Medicaid, or HRSA funding, which is really the healthcare for FHBCs.
Right.
Yeah.
So about 15% is HRSA,
Right, correct.
where we get a direct grant, and the others are through providing services.
Yeah,
Right.
billing.
$1.18 million from HRSA.
And you're concerned about mainly HRSA or Medicaid or
All of the above.
Watching this very, very closely. Right now, from the HRSA perspective, health centers are in a positive place. We were hoping for an increase in our base. There was some additional funding provided. However, it looks like they're moving toward project-based funding, so not as excited about that, because that means you add more staff and more services, and then you have to figure out how to maintain it. So looking at that, but yes, we are watching. The other thing that we are doing is we're looking at diversified opportunities, funding sources. So you mentioned chronic care management, different places where there's an opportunity to provide better services to the patients, but also there's a ROI revenue opportunity as well.
And I briefly mentioned the 340B program, the pharmacy program. Well, there's conversation about whether we have to pay full and then get reimbursed, which is a huge cash flow issue. So things like that, which is what partially prompted having the team come together regardless of transitions, just simply so we could be more nimble. You know, we needed to know how to pivot if we needed to.
The other thing that we do with our team, with our board, is we and our employees is encourage advocacy. And so we stay very tuned into it, but we also let our employees and our partners and everyone know we really need folks to advocate for the health centers. And so it's an important access to care issue, and we need to make sure everybody does that, including the 340B.
Yeah.
Yeah.
Thank you.
Other questions, Paul?
Actually, I want to give credit where credit's due. Dr. Miranda, after our last chairman's meeting, I had an opportunity, I got a call from one of your board members and I got to speak with that board member. And it was shortly after our meeting, so that board member did not know the nature of the discussions that we'd had here. And that board member shared with me that you had already begun to explore training for your board and your staff on FQHC and some of the other, and I appreciated that greatly. I mean, that to the extent of my inquiry and various topics that have been discussed, it's governance and our scope you've accomplished. In other words, by that what I mean is never intending to do anything punitive or whatever, no matter what, and not that anything needed to be done punitive, but there's no judgment in that, but solely the idea of making sure that our agencies have an awareness and seek to address. And you had done that even before I had mentioned it at our last meeting, and I appreciate that your thoughtfulness in thinking that way.
And thank you. And I appreciate you mentioning that, and I appreciate your comments. So yes, we do an annual training for all our board members. It's a compliance training. So I've been at Treasure Coast for 4 years. I was the compliance officer during that time until I transitioned. So every year I do a compliance training that's based on the HRSA curriculum. It involves conflict of interest. It involves the governance. It involves the role and responsibility and the authority of the board. And there's also some documents that they have to sign attesting to the training. But yes, thank you, Trustee Westcott, for bringing that up. It's a really important part of the job as a compliance officer, and something I take very seriously. As a CEO, I will not be the trainer. Actually, Ms. Damaris Arroyo is our Director of Operations, and she will be taking over that training with the board for this year. We normally do it in the month of July.
And in the Oslo location, what will that look like in terms of access to the facility that you have for other organizations?
So that's a great question. Do you want to speak to that?
Sure. So currently, just to give you context on the campus, currently we have an existing healthcare center, and we're building the pediatric center adjacent, and there is an ability to go to either one. In the back of the property, we had planned a 6,500 square foot building for administration. And then we realized that it was more beneficial for us to be in the building than separate from the building. And all the services that we needed to provide between the two buildings were met with us even moving in. So the thought was that we have, oh boy, handful of collaborations, and it would be really beneficial to have some of them be on campus. Now, right now in the pediatric building, we have a couple of offices where Healthy Start and Pikes and Teens can come in and rotate in the area where the pediatric care is happening. But we started brainstorming that wouldn't it be nice if they needed to anchor and have a larger footprint that we could offer that building as a space. We would given our financial situation, would ask for some kind of a lease payment, but it seemed like a great opportunity to really have collective healthcare. It does have an adult population, so it served, the thought was to serve both.
And my next question is fact finding to help us with some things that we're gonna be looking at as a governing board moving forward. Scouts honor, I'm not going to ask for minutes, but my understanding, I've been contacted by a few people in the community that are involved in this arena that have shared with me that oftentimes with other entities making grants, they are asked for minutes to their meetings as part of the grant process. Has that been your experience as well with some of the other agencies out there?
In terms of asking for minutes from the, I mean, we do get requests for minutes from the board meetings.
Right.
That's not an unusual request.
That's all I wanted. Thank you.
Any other questions?
Okay,
Well, thank you.
Thank you.
was that all?
That's it. Unless you want to address that.
We do need to look at, in your packet, that was, yes. Sorry. There was information, based on our meeting last month. The information that we requested and the information that we did not request, is included in this packet. Dawn, as our auditor, reviewed the information that was submitted. In here you have her report, on her findings. And she did have 4 recommendations on, page 4. That I want to bring before the trustees and, have a conversation about them, so. Jennifer, Dana, when is?
I'm just looking at it, but this is, so,
I looked at it online and I probably should have used myself.
yeah, I think you should recuse yourself at this point.
Yeah, so I will.
Okay, thank you. So Dawn, if you would just quickly, what the recommendations are, so the trustees can discuss.
Sure, absolutely. So my recommendation was to request a liquidity stabilization plan. So what the plan is, I'm sure you all probably have something in place, even if it's a rough draft, but just for the district to have a copy of that plan. Just review, monitor the audit status carefully. I know we're waiting on that financial audit to be completed. Just fully understanding CFO recruitment. That doesn't have to be anything formal. I think you have regular conversations with our executive director just to kind of keep him abreast of how the recruitment process is going. And how your financial oversight is going. Sounds like it's going very well right now with Warren at the helm. And then just monitoring cash monthly for the next 6 to 12 months, which I'm sure is everything that you're already doing. Yes.
Yeah.
And those are just my recommendations, from the district. It sounds like things are really, making a turn for the better, so that's great. And like I said in the report, this is only a 3-month snapshot of financials and not audited financials, but, in looking at it, and there's definitely some positives that came out of it.
Absolutely. Any questions from trustees on those recommendations?
Just growing out of the report, Paula Scott, and it had been reported that at least one key staff had been asked, or I don't know, was asked or offered to defer pay. In these times where you're doing difficult work and making sure that financially, I'm sure you're doing this, but I can't sit here and not say, those sorts of decisions have tentacles potentially in terms of funded agencies and grants and things. And your ability to do that, I would just ask that you guys, if you aren't already being diligent, be very diligent, seek legal counsel before you make those kinds of decisions so that you don't have any, and you may have, but.
Just to clarify on that, since I was board chair, when that, my understanding is when the deferment happened, it was voluntary and it was only one person.
Okay, and even if it's voluntary, I think that it talk, it sounds like promotion of my profession, talk to a lawyer. Um, and I want you guys to be safe.
Okay, any action needed from the trustees, regarding these recommendations from staff?
I think you could do a motion to recommend and then just reiterate the bullet points.
Anybody, anybody interested in making a motion?
Before, some of these. We probably should have some timeframes, and you all should probably participate in what's feasible for us to ask, for instance, requesting liquidity stabilization plan. What's a reasonable period of time for you guys to be able to
We
deliver
already
that?
have it. The $2.5 million.
Yeah, okay, yeah.
We have it, yeah.
What is the monitoring cash monthly, gonna look like? Just cash on hand?
Yeah, it would be, we do it now for our board, it's part of the
Yeah.
board package.
Okay,
Daily cash on hand by week.
Okay.
Yeah, that works.
That would be perfect.
Yeah.
I don't, it doesn't sound like this is a heavy lift.
no.
I think they're doing it.
Yeah, well, I just, before we made a motion, I think it's helpful to know what sort of boundaries we need to have for, yeah.
So I still need a motion.
Maybe for like a.
I move that we accept the,
Monthly check-in.
Yeah, cadence.
Yeah.
and Don's gonna be doing it, I'm assuming?
Well, we could say monthly check-in with the executive director and I'll communicate the relevant information to Don.
And so that's the motion.
Has it,
That's right.
has it been, I wanna wrap it all up, that's what I was asking.
Hang on, is Michael on Zoom? Because we don't.
I saw.
Yes.
Yes. Yes.
He is, he just didn't say it. I wanted to make sure we do, because I only see 3 people.
No, we have 4.
Okay.
1, 2, 3, 4.
All right.
And I'm not going to name Don, I'm just gonna say staff, just so that you guys have the discretion to do what you need to do.
Michael is on and unmuted.
All right.
Michael?
Yes.
Hello.
Okay, thank you.
I move that we implement the recommendations of our Director of Accountability and Compliance with the 4 points enumerated in the report, that she engage, that staff engage in monthly check-ins, including requesting a liquidity stabilization plan, reviewing audit status carefully, fully understanding the CFO, assisting us in fully understanding the CFO recruitment and interim financial oversight structure, and monitoring cash monthly for the next 12 months of TCCH.
Do I have a second?
Second.
Any discussion? All in favor? Aye.
I,
Okay, thank you.
Aye.
Opposed? Hearing none, motion passes. Thank you.
Thank you.
No,
he's getting better, that's great.
Yeah, it's. I hear that, yeah. Okay, yeah.
Right, from our. Well, I pushed him there when he was talking. I can change that.
Well, good math, right?
Great, okay, we're back, to the agenda item that I had, the communications and media policy. You have at your place the current communications and media policy that was approved by the trustees back in February of 2025. Does everybody still recall this policy? Okay, no.
Oh, absolutely.
Absolutely, you poured over it, you knew it back in February 25. I put this on the agenda because after reading the May 14th article in Vero Beach 32963 regarding an incident that happened in the area of Thrive, but completely unrelated to Thrive. which is one of the district's value partners. I think we can all agree on that. I had some questions that I thought would be an interesting case study of putting this media and communications policy into action. And so I just wanted to lay out a few concerns that I had, or a few questions I had regarding this. First, I wanted to state that I found many of the words and phrases chosen by the reporter in that article to be inflammatory, lacking in humanity, and certainly not within what I believe the district's core values are. And as I heard, words matter. I don't want anyone to think that the district thinks in the same way as what was depicted in that article. Okay? A district trustee was quoted in the article. Although the executive director, my understanding, was not contacted as the official spokesperson, as outlined in the policy, a district trustee was quoted in the article.
Use my name, it's me, you can say that.
Okay, Paul Weston, District Trustee Westcott. I'm concerned also that I learned about Trustee Westcott's position and the current rationale for that position on a matter that we have been discussing around this table for the last, 6 or 9 months, most likely. That I learned about what seemed like a new position in the newspaper before we had the chance to discuss it here at the table. So I reviewed the policy, made sure that I understood it in relation to this story. And so I am bringing it forward for discussion as a case study, and to make sure that we are all on the same page as to what the policy is. And if there's any clarification that we need. So Trustee Westcott, you were contacted by the reporter for this article?
What was the new position that is expressed here?
The safety issue. I had not heard that from you before.
Had several meetings on this, I'm pretty sure it was part, but if not, but in the context of the article, what are the negative implications of that?
It was just that I was not aware of that position that you had, and it was in a newspaper article that was out there in the community.
And
I think it's something that we should have discussed at the table before, and you are not the spokesperson for.
I never professed to be. That's not in there. I never said, never have I said, actually, I say just the opposite. I'm typically 1 or 2 of 7 on any particular view more often than not, and I say that frequently. I'm the opposite of a spokesperson for this organization.
Unfortunately, you're listed in here as a district trustee, and so. But anyway, so you were contacted by the reporter,
Yes,
right? Okay, okay. And the reporter didn't contact.
I had no knowledge of that.
Yeah,
No, I was not
no, okay.
contacted.
So I'm just concerned that we have a policy
This
that,
is patently unconstitutional. Like this is prior restraint. It's a policy that is unconstitutional because it tells trustees, elected officials, to not speak to the press. Or so it's patently unconstitutional as prior restraint.
if that's the case, I'll.
And I said that when this was adopted. I think I voted against it.
I do recall that, yes, I do recall that. So if that is the case, then maybe we need to look at this policy, because we cannot be unconstitutional.
Right, I mean, certainly we're not looking to do that, and the goal of the policy is pretty well spelled out in the document itself. Trying to make sure that what's communicated is consistent
with what's discussed at our board meetings and that we have a process, and that's not uncommon for any organization to do so. No one's trying to limit anyone's free speech rights.
And we're gonna do that today.
I'm sorry.
Terry is here today to talk about the proposal, and we're gonna have that conversation. We're gonna do that here and now today.
Correct. We're gonna have that conversation, and so certainly this is a matter that's everyone is aware is gonna come before the board for discussion and a vote. I think that goes to the concerns of trustee Bartlett is raising, that she's reading your opinion in the article before it's discussed at a meeting with the board, an additional portion of your opinion. Certainly, I know you've voiced concerns about the zoning. I do know that, and that's one of the quotes. The other quote, though, indicates additionally, this recent event raises the topic of safety and security for the community. Families around those who need the services are likely in some form of crisis. Security of the residents, care providers, and the community cannot take a backseat to our desire to provide the necessary services. And then it indicates, again, you're not quoted here, it just states you would rather sell the property outright. Instead, you support what Thrive wants to do, but not the 10th Street location. I think that goes to her concerns.
Right, and that's an inference she's drawn from prior comments that I've made, I suspect, because I didn't. She's not quoting me.
So that last part was not a quote, but there are two prior quotes.
Dr. Mackett, you had a question or?
Just a comment based on what I'm hearing, and I do remember the policy, although I needed to refresh. So Dr. Mackett speaking. I think two people can be right here. I think I agree with trustee Westcott that we are always free to talk to a reporter, to a constituent, to share our opinions and our viewpoints. But I don't think we are free to speak for the Board of Trustees. And I think we have made clear in this document that we believe that the executive director should speak for the organization when an opinion of the organization is asked for, or some clarification, it's communication, et cetera, et cetera. So I think at least for me as an individual, this just reminds me that I need to be very clear when I communicate with constituents and with reporters, et cetera, that I'm representing my own view and not the views of all of you.
And that's my SOP.
Okay. Good case study, good reminder.
Reminder.
Thank you.
Okay, next on the agenda is Thrive. I hope that we will set that aside and focus on Thrive and the business that we have today. In your packet, you have the lease with option to purchase document. Dana?
Absolutely. Thank you very much, Madam Chairman. So in your packet, we do have the most recent draft of the Thrive lease agreement with the option to purchase. There have been individual one-on-one reviews of each trustee, not together, each separately of this, just to provide feedback as to certain portions to be provided and put into this agreement. We have also consulted with Thrive as well, so that we have an alignment, at least from intent and meeting of the minds, on the overall structure of the agreement. So now what we'd like to do is go through, have comment between the trustees and questions here to be discussed. And I'll go through quickly. I know we've all looked at this, but the quick high level of what's in there, and then we can open it up for discussion to see whether or not there are further questions, additions, being ready for approval, etc. One of the things I do want to state at the forefront is the term of this agreement, should it be approved, is not scheduled until July 1st. So if there are questions, if there are additions, if there are comments, there is no rush to approve this today and or tomorrow. We can say, we will approve with the addition of, or there's some contingencies, and we can agree to bring this back for the June meeting. So there is no need to think that this absolutely needs to be done today. I know that there have been some changes as we evolve through the different provisions in here, so I just wanted to lay that out on the table preemptively. All right, so we'll go into the general terms, high level. I won't go through all the details because I know what's in here can be discussed and will be. But again, the term we discussed was a 3-year period, which would start on July 1st, would end on June 30th, 2029. There are requirements or contingencies that Thrive has agreed that they would perform in exchange for the rent abatement. So that's where here, if there are any questions on that paragraph 4 to be asked of Thrive, we've gone through these with Thrive and making sure that that makes sense also for the trustees and Thrive, that this is what the deal would be in exchange for the rent abatement for the 3 years. We do have in section 6, the repairs and maintenance, interior versus exterior, who is responsible for what in the building. Again, if there are any questions or discussion points there, we can definitely delve into any of the specificity for either of those sections, the interior or exterior. Same with alterations and improvements. And then one of the large provisions as well is the option to purchase. So in going into this lease, the idea was within that 3-year time period, should Thrive elect to exercise the option to purchase, they have the ability to do so. There is language in here that says that election needs to be approved by the board. So we do have a collaborative agreement about the exercise of that option for purchase. And then there is the process in here that states how the appraisal will be done, how the fair market value will be determined, and then a final vote by the trustees to approve that end price. And that gives you kind of the high level of everything that's in here, and I'd like to open for discussion on the document.
Questions? Alan?
Alan Jones, I support this agreement. However, I would prefer, and I think it's more consistent with our process here, that the word option be changed to intention. There might be a distinction without a difference, because they would be not obligated to do so, because the intention is certainly not black and white. But it's closer to what I understand our agreement is, and I've discussed with Fry, that they intend to purchase. And I would prefer the term option to purchase be more clearly changed to intention to purchase.
And I will note on that, so the general language in a lease agreement that has an option to purchase is an option. I think it is aligned with exactly what you're saying, Trustee Jones, that is their intent, and they do have the ability, as soon as either the capital is raised and they give notification that they want to purchase, so it can be before that 3 years as well. But that's all laid out in that option. That's more so the legal terminology that's standard for a lease of this
I
type.
recognize that, but
And
I would like our lawyers to figure out a way to have intention.
I can add that language in with it's the intention of Thrive and the district to provide this chance to purchase the building with that language that's in there that says with the notice provision that you can purchase early with no penalty, all of that is in there.
No, I just want to be sure Carrie and Nancy and everybody agrees. I don't want to speak for them. I thought we did, yeah.
Absolutely.
Okay, well, I like it better with intention.
Duly noted. Other questions, comments?
Yeah, that's fine.
Paul?
Sure. Page 9. It would be D on that page. I think we could, if they choose to not exercise the right to purchase and we get inside that 12 months, what happens? I know what happens.
Yeah.
But I'm not sure it's clear here.
So you're saying if they choose not to exercise, but it's beyond that 12-month time frame in which they have to provide the notification?
Right, so what does the district get to start doing? Do we, at that point, can we rely and put it out for sale? Find other tenants? What are our rights under that circumstance? I think need to be more clearly stated.
So that
If I may have overlooked it, by the way, for the public's sake, in order to not violate sunshine and so forth, sequentially, the trustees have been given the opportunity to review the document, and everybody's got busy schedules. I don't think when was it, Wednesday or Thursday last week I saw it. So no hiding the ball or anything like that, but just the mechanics of getting this work done.
Absolutely.
So that's one observation that I had. And the other one is probably more for our conversation on page 10. Lowercase Roman numeral 4, it talks about our ability to discount the price under some circumstances. Statutorily, are we allowed to, one, sell it for less than fair market value?
So as long as there's full discussion on it and documentation of what exactly the costs are for the decrement. So has to fully be discussed, just like any purchase, if it's fair market value and there's some reason for carrying costs, what we've listed here, any operating expenses, or the documented value of health related services.
Prospectively or retrospectively for services already rendered?
So for A, the documented carrying cost, all of that's retrospectively, obviously, and then for health related services, that would be, it could be prospectively, but that's all going to be within the discussion. If there's a decision to say, this is what the value is, we know that there's going to be additional community benefit from this, that was part of the deal from the start. If that's what the trustees decide, then absolutely.
I think we serve the taxpayers if we, under that paragraph A, that the trustees in the future be asked to consider the value of the rent abeyance as well. In other words, if the expense of operations, the benefit of having the facility at a rent-free basis should likewise be considered. Hopefully, we're not gonna have a conversation because everybody's gonna give them a whole bunch of money and they're gonna be able to do this just fine. But if we find ourselves there, I think we probably ought to contemplate that in the agreement up front.
Okay.
Any other comments?
Actually, I see that. Page 6, under insurances, I don't know, this may be more in our contract services agreement. And I don't know that it's relevant to the services that are being provided. We have, it's the insurance language. There is general liability, but is there any relevance for us to have E&O coverage listed as well?
So
And I don't know if that's anything that they trigger with the services they provide or not, if it's part of our services agreement with them. That was another thought that we.
right, and that's where, from a lease perspective, we're looking at what your overall liability would be on the building, like any landlord. So the discussion here is whether there should be a mandate to have an errors and omissions policy for the operators at that particular.
And it's, I agree, under normal lease agreements, it wouldn't necessarily have it, but this one has a service flavor to it as well.
Yeah,
That's why I'm bringing it up.
and there is indemnification. I mean, that doesn't necessarily help to prevent any of the initial damages that could be covered by insurance. So I think that that's a reasonable ask to just at least mandate that there is E&O held by Thrive for that particular location. I'd like to have your input on that, if that's something you would already have at that operating location.
We do have directors and officers insurance, and within that is where our E&O policy is at.
This is different. I'm thinking, and I hate to use the M word, but the M word that goes along with the provision of medical services you know, I don't know if that's an issue for you, the services you all are providing, but I think it's something that needs to be required, and by M, I mean malpractice.
I don't.
Professional liability, but we won't be providing clinical services where the professional liability comes to play at that location.
Yeah, we definitely have professional liability insurance, malpractice insurance. We do not have licensure to carry malpractice insurance.
This may be a good conversation to have with your insurance agent and your counsel, because if I were a creative PI lawyer and something were to occur in this sphere, I'm gonna sue everybody and let the jury sort it out.
Because, I mean, I will say, we have a very collaborative relationship with our insurance agent and who we use. I am a believer in being overinsured in all areas.
That's my point. Thank you.
That's where I have operated, and that's where Thrive operates as well. I do know with medical, that for certain malpractice insurance, you have to have certain licenses. I don't know that we'd be covered in there. I certainly will talk with our agent, make sure that our professional liability covers that, and I mean, we have already taken this lease agreement to our insurance agent to make sure that we're in compliance with the request as it's stated. And have ongoing conversations with our agent.
As a licensed clinician, my understanding of my professional liability insurance is that is the malpractice of our field,
Right.
but we can verify if there's more the organization needs.
Michael, is there anything that you'd like to ask? I don't wanna leave you out.
No, I'm following all that's been said and I'm in agreement. I don't understand E&O. I'm not an insurance guy, but whatever appropriate, I'm sure Thrive will undertake.
David, do you all have an umbrella policy in addition? I thought so. That's what I wanted to ask. It's an additional one lane.
Our umbrella's 3.
Okay.
Dr. Mackett?
Yeah, Dr. Mackett speaking. Yeah, I share all of these concerns about liability insurance, umbrella. My only question about the lease or concern about the lease is I don't want to narrow the language so much that we don't allow them to succeed. So I think we're interested in potentially umbrella, professional liability, but I would appreciate continuing to have the language suitably vague in general so that they can pursue what they need without us pigeonholing them to specific insurances, et cetera.
Okay. Note taken.
If I may, and the language you're asking for is something that creates enough of a definition that if for some reason we had a disagreement that found its way in the courts, the judge would be able to discern and decide it for us. So any and all relevant necessary insurances at appropriate levels, given the nature of their activity, that sort of language, as opposed to telling them what the insurance should be. Because this is gonna be an evolving project too. Carrie and I've had a really nice conversation, and I'm gonna, if I may, at some point, I think some of the things that we talked about may be helpful for the folks that may have concerns.
Anything else? Are the trustees comfortable? Would we like to see the changes in the updated lease agreement?
That would be my recommendation. I'd like to give a full final to
Okay.
everyone. That way we can update this provision in the insurance to make sure that it encompasses both what trustee Westcott and trustee Mackett were saying, and then we can recirculate for the group.
Okay.
And we'll request public comment before we approve it.
Would you please redline? the changes?
Yes, I love it.
Would that be available for tomorrow night?
Do you wanna vote tomorrow? Yeah, I mean,
We can do it if you guys want to do it
Yeah.
tomorrow, or if you'd rather wait to June, that's up to the board.
This is Frank Geisy. The only reason my only concern is I want to make sure that these changes made in red line are, the trustees have ample time to see, review, digest before tomorrow night at 4. And I don't know how in the world we're gonna accomplish that.
and I do wanna say, just from a mechanic standpoint, we wanna make sure with the final insurance language in here, if Thrive does need to rerun that by their insurance agent to ensure that they can comply, we wanna allow that time as well.
And again, remember the lease isn't set to start till July. So even if you approve it tomorrow night or you approved it in June,
Still good to go to.
yeah, there isn't a rush for that reason also.
No reason to rush to our demise.
But we'll do whatever the board prefers in that regard, but.
I think I hear that we would like to wait in June.
I feel fairly certain, I know, John's Island Foundation was giving us till May as kind of in their communications with us. I have updated them on our progress on the vote of the approval, and then that we would be discussing and hopefully signing a lease today. I will, make a phone call when I get back to the office. I have good faith that they will give us till June to get that lease signed. If there's an issue or concern, I
I can write you a letter.
I can
I'd be happy
immediately
to
reach back to Frank if I need
and
something.
talk with someone. It's just gonna take-
I had a conversation with Carrie Lester that I think will be helpful. Do you mind? It's gonna seem like I'm cross-examining her. I'm not. I warned her, said.
He already did that to me.
I think the conversation you and I had is gonna be helpful generally, and I'm gonna kind of lead it along just to kind of help the process. One, you're already contemplating and looking to have law enforcement assessing the property and kind of helping you make sure that you are taking appropriate precautions.
Absolutely. Our current office, that's how we set up our new office is with the security. We had people walking the grounds advising us, which is really what helped us with the incident because we had camera footage that helped really tell the accurate story of what happened.
And she already had a sensitivity to traffic around the place. What I'm gonna ask you just to affirm what I'm getting ready to say. Patients are not gonna, or clients are not gonna have visitors, so that there's no traffic in that regard. She and I talked about how to pre-screen, that she's gonna explore having law enforcement that may be bringing somebody, make a phone call first to make sure they're being brought to the appropriate location.
We are already working on very clear exclusionary criteria, because that's the key to the success is really making sure we're getting the right people coming through the door.
As far as landscaping and so forth, out of the interest of both the privacy of the clients and not that necessarily having them living there is gonna impact the community, but you're gonna have landscaping in order to be inward looking and create a more private, secluded environment.
Very, very similar to how it is.
That, I was gonna say, that property is really lends itself to the privacy and to the campus feel for it.
And as far as the commitment from the client, the nature of your other grant relationships, you have rules and things that you already need to follow that govern how you interact with them. Your
Absolutely.
clients.
Yeah, so all protocols, policies, procedures are all really determined by our CARP accreditation and our bar certification.
And you have similar facilities in the community that have not had any issues and that you're already having to operate under those procedures and protocols.
Absolutely. I mean, I'll remind you, we've been in this community serving for the past 36 years without incident, and we currently operate 2 recovery homes for well over a decade without incident. And we really value a good neighbor policy, right? No matter what we do, where we're serving, it's about being a good neighbor and working together and collaboratively with our neighbors, and we've had no issue.
Now the one wrinkle that the lawyers probably need to work out is we have a county residency requirement with how we provide services and funding. We need to make sure that that doesn't bump into your other funding, and we got to figure out how to navigate that. Has that been any part of the conversation so far?
So we have looked into this a bit and there's been discussion. I know Frank has also had some discussions with Terry on this. So if you were to take what the fair market rent value would be at around $25,000 per month and compare that to the overall operating expenses and the other funding that's received for Thrive for that location or would be prospectively, it really only equates to likely less than 30% and probably far less than that is what the district is providing with that rent abatement. So if you look at the dollars provided from the district versus the dollars provided from other entities, including federal funding, there is a much lower percentage. If we were to say the dollars have to match the percentage of Indian River County residents served. I know that Thrive, and I don't want to speak for you, but on average have 95% in county. So when you look at those two comparative, there shouldn't be an issue covering more than what the money covers from a percentage standpoint.
I just want to make sure that we're following our legal
Yes.
obligations.
We have looked into that and talked through how that would equate from a percentage standpoint.
And we will continue to monitor and report zip codes and those kind of stuff. Yes.
Is that all? Paul?
Yes.
Okay. All right, so we're going to continue working on the agreement and we'll have that back in June for anticipated approval. Okay. 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 Anything else? We're good?
If you need a follow-up letter, connect with Frank on it.
Connect with Frank on that, and I just wanted to thank Dana for her work on this. We felt like it was a very collaborative exercise, and we reached a place that I think the spirit of last month's meeting brought us to. So thank you all.
Alan?
That is, falls in the category for what it's worth,
Mm,
but I just would like to say that, at least speaking for me, I think Thrive is an extraordinary organization that has provided services to our community, as Terry said, for 36 years. And this agreement enables us to take our dimension of service to another level. That communities much larger than us have, because they can afford it. But our community does not have, but still needs. And it's one of the things that differentiates Indian River County is having things like the museum, like Riverside, Cleveland Clinic, et cetera, really things that are normally in large cities. But here we have a chance to do it here. We have the same needs, but a much smaller population. So I really endorse what Thrive is trying to do. And just speaking for me, I just admire the organization, and I'm sure we'll be able to work to an agreement that serves the taxpayers as well as the community needs.
Thank you. And if I can piggyback on Alan's comments, I think that we're gonna find one of two things, and it's gonna be the latter. And Carrie and I had this conversation, is we're gonna find, wait a minute, this is more than we need, not likely. Or we're gonna find it works and there's more that could be done. When I first came on board, there was a conversation about medical detox.
Yeah.
If we get into that, we have to be closer to the hospital. So I'm not sure we're gonna consummate this sale to them, because we're probably gonna find that this program is gonna develop and grow and need to be someplace else. So get busy.
Or they make the property more valuable when we do something.
Yeah.
Well, to that point, the investment is modest because it doesn't require a great build out from what she shared with me.
It is ideal, and we'll continue to, I mean, it is ideal for us to go in and start this operation and collect data. If Paul asked me, what's your wish list? Like, what are you compromising? And it's like, nothing, right? Like,
Right.
we got the recovery support beds. Like, this property was uniquely positioned. We wouldn't be able to find or replicate another property like this. So it is ideally positioned for what we need to do to support the continuum of care and meet the needs in the community.
And I will just add, my name is Nancy Lynch, I'm the chairman of the board. I thank you for your comments, Alan, especially. We have had probably close to 50 visits and tours of Thrive since January, where we bring people in, not necessarily all donors, but people who are interested in the organization and learning more about it. And I can honestly say there isn't one person that we haven't sat down with at the board table and explained centralized and respite to them that they haven't been 100% in support of, and feel that this is a exemplary project for the community, for Indian River County to have. So nobody has said to us, I don't understand why you're doing it or what you're doing, but thank God you're doing it.
And I truly, I thank you for your trust in us to execute this project and utilize the property, but really thinking bigger on being an example of how do we leverage resources. I think we are going to be very proud of what we've accomplished and what we've shown on the return on investment. And it takes the partnerships, it takes the different resources coming together to make big impact. And that's what this will be.
And on that note, thank you.
Thank you.
Thank you.
Okay, moving on to the decom follow-up discussion. We've got some action on that as well. I'll ask Frank to update us.
Sure, so we've got some substantive items to report as we received. If you remember our meeting last month, or perhaps it was 2 months ago, last month we did the extension. We had interest. I received interest in terms of an email from the leadership at Edward Via College of Osteopathic Medicine, who expressed their interest in purchasing the Human Services building and the associated acreage on the Cleveland Clinic campus. And so just recently, within the past few days, we received an official purchase contract commercial purchase contract from their legal counsel. For them to purchase the property at the appraised price of 4.65 million. And I'll turn it over to Jennifer, for the rest.
Yes, so, Friday, last week Friday, I spoke with, VCOM's legal counsel, who is Randy Schuler. And did confirm that his client did have the intentions to, purchase the building and the associated acreage, for the legal and the lease, that they are currently leasing. And, at the appraised price, as Frank just stated, of $4.65 million. It'd be a cash purchase, as is transaction, pretty clear, quick close process. So he and I spoke about the process, and I said, I need you to put those terms into a commercial as is contract, so I have something to present to the board, but also to Cleveland Clinic's counsel. So there's several things going on here. We have a purchase offer at our recent appraised price for cash purchase. They would close as soon as on or before July 29th, if we can get this done. They only want a 30-day due diligence period. But in our lease with Cleveland Clinic, we have what's called a ROFR, or right of first refusal, for this parcel that gives them the right to match the exact contract terms. And they have up to 60 days to review and determine if they're going to exercise the right of first refusal and purchase it or waive that. And so today we need to do a couple of things. First of all, we also have a lease that has an extension through today's date. So I believe we need a motion to extend the lease for another 30 days. Because we've got to go through our process with this offer. And in addition, I believe we need a motion from the board that the VCOM offer to purchase the Human Services Building and associated acreage at the appraised price shall be sent to Cleveland Clinic's counsel to review and determine if they're going to exercise their right of first refusal that is in the lease between the district and Cleveland Clinic. Once we know where they stand on that, if you're amenable to making both of those motions, will give us a chance to go through the process. We will come back to you once we have their response. And we will then, if they say we're gonna waive that right of first refusal at this time, go forward with VCOM, we would then present the contract for your review and approval and public comment. I do wanna make one other note about what's in this agreement, which I raised with VCOM and they agreed to. We did agree that they would put a right of first refusal in the purchase agreement to, if Cleveland doesn't exercise it at this time and allows for VCOM to purchase, VCOM would give Cleveland the exact same right of first refusal if they were to ever sell the building.
And us.
Well,
In other words, Cleveland Clinic and the district, I think we might as well, since it's a valuable location. It's just a right of first refusal. All we have to do is say no, if they, in other words.
we could put
He's
that in
got-
there.
Yeah, because he's got a point, because the property is owned by the district. We're leasing it.
No, we'd be selling it.
No. All the other property, the hospital itself is owned by the district.
Right.
So we would need, Paul's right, would be
Right,
both.
we'd look at the language that's in
Yeah.
the lease, basically.
So an agreement with VCOM should retain a right of first refusal for us and Cleveland Clinic. So if they ever choose to sell it.
Yeah,
At some time.
assuming this comes back, I agree with that, assuming this comes back to the board for review and approval and Cleveland waives their right to exercise the right of first refusal at this point in time.
Another comment, Karen Deagle, should we do 60-day extension rather than 30? Because if you have 60 days.
Yes, that makes sense.
I agree.
I
Yeah,
think
we
the
don't have to
math
back it up.
requires more than 30 days.
Just in case.
Yes, we'll do 60-day lease extension, that makes sense.
Do we need to do any sort of a letter of intent so VCOM knows that we're moving forward? And incorporating in it that we've got to deal with the right of first refusal. I don't know what your communications have been. In other words.
Yeah,
And there is a letter of intent that they sent to us. We've been in full communication with them, giving them this exact same timeline. So
Correct.
yes, we've got all of that papered.
Yep, as of Monday, we went back to their attorney and just said, here's the process that we have to follow. And so they're fully aware of that. We sent that to them in writing. I don't believe we need to do a formal LOI since we've had that communication.
Just curious.
just follow the applicable Florida laws for the sale of real estate.
So the first motion is to extend the lease by 60 days.
Yeah.
So moved.
So
Okay.
Any
I'll
discussion?
take this one.
Yeah, you say that.
Any further discussion? All in favor?
Aye.
Michael.
Any opposed?
Aye.
Thank you, Michael.
Thank you.
Sorry. Any opposed? Okay, motion passes. Second motion.
I move that we direct council to send a letter to the appropriate elements of Cleveland Clinic, informing them of the potential contract for purchase and sale at the stated price of 4.65 million, and invoke the right of first refusal obligations that Cleveland Clinic has.
Second. Whose turn?
Go ahead.
Okay,
Oh.
thank you. Any discussion? Dr. Mackey?
I believe I heard that should go to their chief legal officer. Right?
Yes, anything that comes from us, we have to send to their legal
So
counsel.
maybe
We
the
can't
motion
send it
should
to
be
like
worded that
an
way.
employee of the organization.
Is it appropriate to?
Yeah, I think you
Right.
said the appropriate
Elements?
element or individuals, channels.
Okay. All in favor?
Aye.
Aye.
Any opposed?
Aye.
Yeah. What do we need to do? We need to do public comment
On
on it?
any motion we take, I think we've got to have at least ask.
I didn't do it on the last one. Any public comment?
Good point.
Well, again, remember, this is just going to send it to
Yeah.
Cleveland, to determine if they're gonna exercise.
Okay, no public comment. All in favor?
Aye.
Aye. Any
Aye.
opposed? Motion passes. Great, thank you.
Good job.
Okay,
Cleveland Clinic has the right of first refusal, but in the event that this thing was completed and we have a contract for 4.6 million comes to the district.
Yes, we would sell it, and if Cleveland waives the right of first refusal, we would sell it. And we would put in an additional deed restriction as part of the transaction with the right of first refusal if VCOM were to ever sell it for the district, as Paul was indicating, and Cleveland Clinic.
Yeah, I'm just.
And we'll work through that language.
where's the money come?
Well, the money comes to the district. The district owns it and the district is gonna be
I'm just
selling.
trying to underscore that point.
Just a quick question of policy. Do we need to make this surplus property resolution like we've done in the past?
Potentially, if we get to that point, but
Yeah, it's
we're not to that.
Okay. Thank you for the note. Yeah, Paul.
So, sorry, my lawyer brain can't stop. If Cleveland Clinic, for whatever reason, is no longer operating our health, we still want them to have the right of first refusal,
All
Not-
of those terms can be built in,
right? So,
because we have a very long-term lease too. Thinking that too.
75 years.
yeah, but I think, again, it's the what ifs, what if,
Right,
the what
right.
if, the what if.
And who gets the first right of refusal? Is it us or is it them?
Flip a coin.
We have to look at what it says
Right,
in the
well,
lease.
and that's I think what Karen's asking is if in the sale agreement, there are two rights of first refusal. So VCOM would have to run things by both the district and Cleveland Clinic theoretically, if that's what's approved as a term. Who would then get the first right out of the district and Cleveland Clinic?
Right.
I think we would want that.
Yeah.
We would, that's
Agree
where
with
I'm
you.
going. We would.
Mac.
Yeah, Dr. Mackett speaking, just a comment, my understanding and Frank's and my discussion with VCOM and with Cleveland Clinic is that locally, verbally, they have said that they're not interested in the property, but I think we're doing the right thing sending this formally to legal counsel because they will need to bless it in Cleveland.
They absolutely have to.
Right.
We granted them the right of first refusal on this parcel if we were to ever sell it when we did the lease back in 2018,
And who knows? I mean, it's
because of where it sits. No, we have not talked to them yet. I mean, this just came in on Friday, end of day. Really in the evening. I shared it with Frank Saturday morning. And so here we are, not even a week later.
This is Frank. I did speak with Dr. Rothman last week that we did get an email from VCOM that they were interested in the purchase and we're waiting on a potential purchase contract. So, but again, you know, running it through the operations of our hospital versus running it through legal are two different things.
Okay, moving on, approval of updated purchasing and procurement policy, Dana.
Okay. So we have been going through, Don, Shannon and I, several policies to either get them updated just as regular housekeeping, or to add things that are going to be relevant to the prospective grant that may be awarded in the August timeframe. So this policy actually falls into both of those categories. This is the procurement policy. And the updates that we made here are twofold. So I'll go through just the housekeeping updates that were made first. So the first updates that we made just had to do with clarification. There were a few sections in this policy that referenced a later subsection that didn't have the right letter, for example. There was a reference to subsection D, it was supposed to be E, those type of cleaning that doesn't change the substance. There's also a change, I want to point specifically to the second page regarding capital purchases. So that's where I have my policy here. I don't have the colors, but it should be in here with a different color. So we have, oh yeah, it's slightly lighter. So in subsection B, Roman numeral 2, we did update the language here. It should not change anything in application of the policy. It was purely to clarify. There were questions where it said within certain thresholds, but it didn't link back to those category thresholds above. So we made it abundantly clear who has decision-making authority at what dollar amount thresholds. Additionally, what requires bids and what does not. So there were three different sections that actually said slightly different wording. We consolidated those down, made sure it was all very clear about when an RFP is required and when it is not. So as you see here in subsection B2, it states that the policy of the district to require bids for the following expenditures without the need of an RFP. And it states as capital purchases, and then you have other expenditures as well. And then further down, we have the professional services and language that is added in here regarding how professional services are procured, the evaluation timeframes, and then linking everything back to those dollar amount thresholds. Anything below that 35,000 is executive director approval. Anything above 35,000 goes to the board of trustees. So again, should not be anything different in application, purely clarification, since there were some discrepancies in the prior policy.
If memory serves me right, I think that tracks with our discussion and our comments, so.
Yes. Yes. Yes.
Question, Karen D.
Yes.
Formal competitive solicitation, so. How are you defining the difference? You have, well, first of all, on page 2.
Yes.
B2, anything over 35,000, you need 3 bids,
Correct.
right? But then, and that goes. How do you decipher what you need to do a request for proposal for?
So anything else that's not contained in this subsection, so this is bids for, that's without the need of an RFP. So if it doesn't fall into this subcategory, so you have capital purchases, and then you have other expenditures, so that's talking more of.
But what types of, I guess I'm a little confused as to if you're doing capital items, so capital items could be anything from a building to, well, repair of a building, maybe it might be,
Computers. Yeah.
yeah, exact generator, you know, that kind of thing.
Right.
So if it's over 35,000. When does an RFP kick in? That's my question, that's all. When would it kick in?
So for those type of expenditures, there isn't the need for the RFP as stated here. It's just whether or not you need to have those 3 bids and then who gets to approve based on the dollar threshold.
So when would an RFP kick in? When would you have to do an RFP?
So.
Yeah. Yeah.
Right, so you go into category 4.
4, yeah.
No, what's that?
I'm trying to figure.
Page 4, formal competitive solicitation, request for proposals. Commodities, contractual services and professional services.
So as professional services, those that are not set forth in that subsection B3.
So cleaning services, if for on an annual basis, you have you're procuring cleaning services and it's over $35,000 a year, do you have to do an RFP for those services?
Yeah, quite if you consider that professional services. Yeah.
Right, and going back to,
There may be more definition to be put in.
yeah, because,
Internal capital type purchase.
yeah, because if you're going to be purchasing something, if this table is gonna cost $35,000 or $40,000, how do you procure it? You might, you're saying that we just have to get 3 bids.
Right.
You might have to do an
Capital purchase, as opposed to anything else that's going to trigger an RFP requirement.
And. Yeah,
So I see what your question is here. We can take a look back at this again.
Yeah, please.
Section 4 is fully vetted as well.
I do RFPs,
Mm-hmm.
my procurements, this is kind of something that we have to do because of Fed money and everything like that. I can provide some of a policy, I'm sure you've got it though.
That'd be helpful though, so if you've got,
Yeah.
you've got like more
Sense of
experience with that
Yeah.
versus. It is confusing, I've read the same.
It's very
sometimes,
confusing
it's
and
like,
I like to.
It's almost like if then and.
Right,
Joint
yeah.
venture.
I will
Really
I will
is.
get you the county's RFP process because we follow along with that as well.
Yeah.
And I think that simplify things.
And I think maybe what we'll do is, we were trying to edit the existing policy and that may have, it
Make it
may
harder.
be smarter to start from scratch. Because there are so many different things that have been patched in here over time. Okay.
Well, just
Okay.
for those sections.
Yes, yeah. And
I
then,
mean, yeah, we can use some of this, but just,
right.
we're trying to piece things into it, makes it almost parts contradict other parts.
Yeah,
Would be very confusingly.
it doesn't have to be this complex.
Excuse me, can I jump in here?
Yes, Michael?
Yeah, on page 7, there's a section that has exceptions to competitive process where I think there's been an attempt to try to identify some things. I mean, you can miss things when you have a list, but I'm saying there's also that section there. I didn't know how that applies to the current discussion.
And I see what you're talking about, trustee Kent. I think the best thing to do would be putting that together with the actual portion that has the exception. So moving it in a structure that makes more sense and aligned. If you're gonna have exceptions to a rule, it should be right after the rule. So I will be structure that.
Oh, got it.
And then also, so I have the notes on all that, so we will update the forefront section of this agreement. So I also wanted to note that we did include, starting at section K. There. Oh, here we go, section L. So starting at section L, we added in the federal requirements for the procurement policy that would be required with the grant that's coming up in the end of the summer timeframe. So this was initially provided in conjunction with our grant coordinator, Ms. Flick. So we have added these in. I have reviewed these. The big takeaway here is this is the federal standard for these particular requirements. They have a lot of this already published, so much easier structure to add in. And the takeaway here is to make sure that it's known that these particular requirements are for the federal dollars. So if there's something that is just the district dollars that applies to a district program that does not have the federal funding, the rules that you have in the district policy would be the prevalent rules. The federal rules, if there is any conflict, the federal rules will trump to ensure it's only if there's a conflict, and you have to look at what the dollars are actually applied for. So we'll work through that. I'll structure this better and have it flow more and bring it back for approval again.
Yes, thank you, Paul Scott. I have a couple, page 2. The last bullet point, I'm a little concerned, and this is certainly no comment on our current executive director at all, but the CPA firm selection, I think we need to, in order to protect that position, any audit or review services that are being performed, take that out, that we're involved with that as opposed, and the reason is if he has the authority.
Be an RFP anyhow.
Yeah, I would, well, I want to make sure that's clearer because if a simple reading of this may be interpreted that the executive director has far more discretion in getting accounting services and legal services. I think to give context, when we hired the engineer last year regarding the VNA property, Frank did that, if I'm not mistaken. We didn't approve the contract. I think those are the sorts of services, one-time shot, engagement sorts of things that probably are the spirit of what's being attempted here. I'm asking more than telling. And
we've actually done a lot of conversation on this because of a different policy as well. So I made a note here. What we can do is we'll reference any other policy. So the policy that we've been discussing is specific about CPAs, how they're selected, and that's purely aligned with the statutory requirement of how CPAs are selected for special districts for government entities. So there is a selection committee. At the selection committee, they put out an RFP. The selection committee has to then review all of the responses, provide that to the board gets to select. Per the Auditor General's guidance, then upon that time frame, once the CPA is selected, there is a review once every 5 years. So the thought process in the other policy that we're still working through at the time is that analysis will be brought to the board, and if there's anything that's a discrepancy from Frank's analysis, the board would then get to decide what to do with that information based upon the periodic evaluation.
then we may want to see both policies simultaneously.
Okay. And that's what we've been working through that one as well, so we can bring that back.
And that was actually discussed at the Finance and Audit Committee.
Any other questions or comments?
Just good job, and we might actually get this done before our term.
Or maybe because of my term being over.
Anything else? I'm gonna, piece of other business on here is a statement outlining the funding review process. We wanted to just, as we are wrapping up our evaluation, our first line of evaluation of the applications that we received, just outlining for us, but also for the public, a reminder about our process. So just give me a minute, let me read through this document that has been prepared by our legal counsel. As we begin our funding discussions for the fiscal year 26-27 cycle, I want to briefly discuss the importance of the work undertaken by the District Board of Trustees and the framework that guides our decisions. Our process is defined by the district's funding application and program evaluation policy. This policy ensures that every application is reviewed through a consistent, transparent, and outcome-driven lens. Each program before us has already moved through eligibility screening and the formal applications process. We're now in the trustee evaluation phase where our focus is on measurable impact, fiscal responsibility, and alignment with district priorities. Specifically, the Board of Trustees' role is to ensure fairness and consistency in funding decisions, prioritize high-impact programs aligned with strategic goals, and ultimately approve funding allocations through a public, transparent process designed to produce measurable outcomes. During this period, trustees are encouraged to submit any questions to district staff. Staff will work directly with our community partners to vet responses and ensure that the information the trustees receive is accurate and complete. If additional clarification is needed, trustees may also request that our community partner return for in-person follow-up. We are now at a critical point in the timeline. The application review period concludes on May 22nd, 2026. After that, our upcoming meetings will begin formal funding discussions. These discussions will inform the tentative budget later this summer, followed by final budget hearings in September. As we move forward, our charge is clear: to invest in programs that demonstrate meaningful community impact, ensure responsible stewardship of public funds, and align with the district's mission to improve access to care. It's a big job, but we're up for it. So, thank you for taking the time. It is a lot of time that we invest in this process. Staff, has a lot of that back office work that sometimes goes unnoticed, but I want to make sure that you all know we appreciate it. You set us up for success. Now it's our turn to do our work.
Yeah, and I could just follow up, excuse me, I'm sorry, this is Jenny. I just wanted to follow up again, Friday, as stated, is the deadline for the trustees to get all their evaluations completed by 5 p.m. And I know I can see from Nate, he's been giving me some insight on who's the star trustee who's completed them all and who's working feverishly. We have to. And who's gonna pull an all-nighter, right? But I did wanna also go over the dates that are upcoming for our budget discussions, because, we did add a few dates, so. Our first one is Thursday, June 11th at 1 p.m., and that is here. And then we'll add the funding discussion meeting onto our chairman's meeting in June, which is June 17th. And then.
9 a.m.
And 9 a.m., correct, going back to the 9 a.m. And then the next one is July 9th. That's a Thursday, also at 1 p.m.
How long are these meetings going to last? Just
I think we've allotted 2 hours,
2 hours?
typically in the past, but we can kind of judge that after maybe our first one.
The schedule as well.
Yeah, exactly.
That would be really helpful.
Yeah.
Yeah, I'm just kind of giving them out there now for
As
public.
I know it's helpful for me to know which one, and I think we did some of this last year, at a given session, who we're gonna be looking at is really helpful,
Yeah,
so.
we talked about that as well, because once I get all the evaluations in and we see that the order of their ranking is, we'll know, and then that way we'll ensure that those agencies are here, so that if there is any follow-up questions, I have received several questions from some trustees, and I followed up with that trustee with the answers, and I'd be happy to continue to do that, but I think it's pertinent that they're here to answer any questions as well. Since that was one of the things that was requested from our last survey from last year. Okay.
So you ended on July 9th.
Yeah, so we'll recirculate this if you want, but then
Yeah.
the next one is Wednesday, the chairman's meeting in July, which I understand it will be located at the IG Center.
Yeah.
So just to put that out there, and again,
What date is that?
that is July 15th, that's at the chairman's meeting. in
That's at
July.
9 a.m. as well.
Correct. And that will tie in a funding discussion meeting. And then depending on how we're doing, we have added 2 more dates, which is July 30th, Thursday, July 30th at 1 p.m. And then the next one would be after, when is our, before our August chairman's meeting, yeah, so August 13th if needed at 1 p.m. also.
Jenny, you'll resend. all
Yeah,
this.
I'll resend that, I just kind of wanted it out there for the
And-
public.
Put the 2 hour in so that I know what to. Look.
And I just want to give you notice that Thursday, June 11th, 1300, I'll have to participate.
Via Zoom,
Zoom.
okay,
Myself as well.
okay.
Okay, so I will put an asterisk by that one to double
We
that.
won't be voting on it.
No.
Right?
Oh.
Okay.
No. It'll be just discussion.
And Dr. Mackey, you got your question answered.
Yeah, it was concerning the dates, thank you.
Great. Okay, any public comments?
Comment, I just want to let the trustees know, I know that we distributed the revised red line internal audit policy last week to all the trustees. I did not make it to get it on this agenda, but we do need to get that approved. It was not approved at our March meeting. So now that we have the changes on the red line version that the trustees asked to look at, we're going to bring that tomorrow. I have copies, so I'll put copies at everyone's seats for tomorrow in case you do need a hard copy. But we will kind
Can I
of
leave with a hard copy?
get approved.
Can I leave with a hard copy?
Yeah, I can give you a copy. Yep. I have copies now, actually.
Yeah, that's great.
Yeah, why don't you pass that on?
Have them around. You wouldn't mind.
Yeah, which reason are we-
I know. Exciting.
Okay, any other business around the table before I go to public comment? Yeah.
Bit of good news, that's been reported, just needs to be mentioned, I think here. Cleveland Clinic, a hospital, and according to Leapfrog. Not saying anything negative about Lawnwood or, you know, just waiting anybody necessarily from going to Lawnwood, but I'm gonna ask the question of our medical providers in the labor and delivery department. And that is, you know, I think there's still sending patients to Lawnwood. And the question I would suggest to the community is ask them why. And it may be a good idea for us to invite that practice to our board meeting next month and ask them why, what we could be doing with Cleveland Clinic to make things more suitable for them so that and have them explain, because as I'm seeing it, we're seeing a degradation of patient choice. Lawnwood got a C score from Leapfrog. Also CMS recently reported their stars at a 1 to 5, they scored a 1. And does that mean that they're necessarily unsafe? Don't go there. I'm not saying that, but it begs the question of why Indian River County residents are being directed out of county, having their families out of county, for services that are being provided here, and all indications would be provided well. And Alan, you know, I'd like to hear from the committee at some point just what we can be doing to work toward the labor and delivery strategy. I don't know what's going on with the committee.
We do plan on giving an official update in June, at the June.
It's scheduled for the June chairman's meeting, and the delay is not the committee. But there are just things keep moving, but I think your point is well taken, and it's like everything else, follow the money.
So, and in the back of my mind, what can the district do to incentivize? And the area we need to incentivize is insured patients.
Yeah.
The indigents are gonna come. And so that one of the thoughts I considered was, do we give them a stipend to provide uncovered medical expenses, over the counter stuff, the patients that choose there? If we could, as the district, allocate funds, what that would look like, what number of patients it would look like, what would be a meaningful dollar amount, just so that we're contributing to the effort in a material way, looking for ways to increase the pressure there.
Yeah, and I don't want to sound like a lawyer. Just because I am not. I would just caution us to investigate first, because what I heard you say, Alan, that there may be some contractual relationship between that practice and the other hospital. So if that is true, I wouldn't want to do anything as a board of trustees that might be interpreted as tortious interference or.
Well, they would likely come back and say, we can't discuss this with you. There's likely some.
Right. They have no obligation at all. Right, and so be it. They can choose to do that. And some time ago, we had a conversation about getting a legal opinion on the boundaries of our ability to encourage our members of our community to stay local as opposed to going to Lawnwood. I'm not sure they may have been lost in the busyness of shuffle, but I think that may be helpful also for us as we're developing a strategy, is to know the legal boundaries of what we can and cannot do.
Right.
You may raise a very good point.
If we could probably safely communicate the grades, the outcomes, the metrics. I just be careful about any inducements.
Agreed.
Right.
So we'll hear a report in.
Yeah.
Okay, great. Okay, any public comment? Yes, please.
Hi, good morning. My
Could you
name is
come to
Dr.
us?
Joe Petunio.
Dr. Joe, yeah, I'm sorry to make you do that,
Okay.
but we just need to get it.
Like me to sit?
Sure, that'd be great.
Good morning, everybody.
Welcome.
Thank you for having me. My name is Dr. Joe Petunio. I'm the dental director at TCCH. My job consists of about 40% administrative, about 60% clinical. So about 2 to 3 days a week, I'm actually seeing patients. And I wanted to tell you a little story about one of my patients that I saw recently. I was sitting at my computer one day in our Oslo Health Center. I was between patients, and when I noticed a name pop up on our emergency column, a few minutes later, a dental assistant called me to go see an emergency patient. And that's when the name on the schedule became a real person. I walked into the operatory, introduced myself, and asked how I could help. The patient was a 45-year-old male. He was extremely appreciative. He said, "Thank you so much, doc, for seeing me. Last night, I went by ambulance to the emergency room for this tooth." I questioned him, "Ambulance, emergency room?" He said, yes, he was in so much pain, he didn't know what to do, and he actually called an ambulance. I questioned further, why emergency room and why an ambulance? He simply did not know where to go and figured an ambulance would take him somewhere, anywhere, for pain relief. At the ER, he was given a shot of penicillin and told to go to TCCH. So here he was with us. It turns out he had an abscessed tooth. We prescribed an antibiotic and a pain reliever and had him back, and we extracted the tooth. And that's a true story. At TCCH Dental, we see patients like this every day. Patients in pain that can't afford dental care and with nowhere else to go. This is the service we provide. This is our mission. We provide quality, cost-effective care to all, regardless of socioeconomic status. Without TCCH, many patients would simply not be able to access care. They simply would not be able to afford it, and they would need to go without it. Whether it's a patient in pain with an emergency, or a young child having routine care, or someone needing a simple cleaning, we are here for our patients and we do not turn anyone away. Thank you.
Thank you very much.
Sharing.
Love ending on that note. Oh, we're not? Oh, good. We have to
On these notes.
Welcome.
Hello, my name is Marcy, and when my husband and I came to Florida as temporary people and then we became residents here, one of the things I knew I wanted to access immediately was getting health care. I called Treasure Coast Community Health, and we weren't in an emergency situation, but I made an appointment, and I go to Oslo, and my experiences, our experiences there have been amazing. I am treated with, my husband died, so it's now but we were always treated with utmost respect. I saw everyone treated with respect, with courtesy, with kindness, with efficiency. Never did I wait. We didn't wait long-term in the lobby thinking, will we ever get in? We didn't wait long in the room for the physician because these things are not effective. Every time there's waiting of patients, another patient probably could have been moved into that slot. So I just want to tell you how appreciative I was. When my husband had needs for increased medical equipment, Dr. B was just all over it. I didn't have to always bring him in. I would communicate with the office. They would give me the prescriptions as we need it. And I can't say enough about what I feel as I listen, especially to your meeting today, and I have all these notes here, but there is no point where you don't access appropriate care from OB to pediatrics to the whole body. And this is so important, and I know you all know that because early detection and treatment is efficiency, and it is wellness and lower cost for your community. And so for everyone who donates or helps you with your services, this is important. So my thing is, thank you for everyone that is involved in Treasure Coast Health. Thank you for what you have available. I didn't have to say, no one said no. How long have you been in Florida? No, we were just, right away when we came as winter residents, we were seen just as like we are now as Florida residents. And that's so important and it's so critical because a lot of people that come temporarily are in the age group that does need more health care. We do need more medications. We do maybe need more frequent visits. We do need more medical equipment. And so I want to thank you, and I want to thank Indian River Cleveland Clinic Hospital also. When my husband needed to come with 911 into the emergency room and when he needed to be admitted, I felt so pleased with the availability of the care service that we have had. And I just feel like it's a privilege to be able to come today and share with you the value with which I place upon that.
Thank you.
Thank you.
Very much.
Can you give us your full name just for the minutes, for the records?
My name is Marcy Hab, H-A-A-B.
Okay, thank you.
Thank you.
Thank you, Marcy.
And here's all my notes.
You did.
If there are gonna be other comments, I apologize. I
Yes.
gotta go. My wife has an issue that I gotta help.
Thank you, Alan.
So I will listen to your comments on the replay.
On the
I
recording.
apologize.
Nope, sure.
I learned that in advance.
Yes, thank you very much.
Good morning, I'm Wilfred Hard. I'm the community liaison for the school district in Ripon County, former board member of TCCH. And I got off the board. My father passed and I started downsizing. But my father was on Florida Community Health for over 40 years. That's out of West Palm Beach. My father was flying to Washington, D.C. twice a year to help write legislation for community health. He did that, and his last trip, he had a massive heart attack and a stroke, flying to Washington, D.C. for his meeting. Thank God, but he passed November. He lived quite a few years under that stress. I come born and raised in Gifford, which is classified as the poorest community in Indian River County as well as the state of Florida. Now, the folks that I know needs TCCH. My father went to TCCH. My sister goes to TCCH. My cousin, my church members, they all go to TCCH. Now, why am I sitting here today talking about TCCH and a former board member? Because I still believe in the mission. I believe strongly in the mission. I was in retail for 35 years. I got transferred a lot. I mean, a lot. Now, why did I get transferred a lot? Because some places just had to be cleaned up. Some places just we had to increase in our sales. And there's a young lady I used to work with right on that corner over there, and she'll tell you, I didn't tolerate too much stupidity because it was business, okay? Today is business for me coming in here because TCCH still means a lot to me. And I'm expecting this board, this committee, to continue to support the mission that you've been called to do. The hospital can't do it all. That new competition that has come in this town, they've been around for 30-some years right here. That new competition come to town, trying to take over, we're not gonna let that happen. I believe in competition, but it takes resources, and it's gonna take some of your resources. Actually, you should be increasing your resources to TCCH, to be honest with you. If you wanna know the truth, go and increase it. I know that there's some concerns out there, but there's the new CEO sitting right over there, a good friend of mine, and I ain't have her. And she's a good friend of mine, and she's gonna do an outstanding job. And if I didn't think she was gonna do a good job, I wouldn't be sitting here. I'll be saying, no, y'all hurt me, get rid of her. I'm serious about this thing. I'm very serious about the mission and the calling that TCCH has. I'm also on other boards in this room here, but at this moment, I'm talking about TCCH. And I'm gonna ask you to do the right thing by increasing whatever you thought you were gonna give. Let the Lord touch your heart and give more. Thank you.
Anybody else?
I have someone on Zoom.
Oh, great, okay, thank you.
Let's see if. There she is.
Hi, good morning. My name is Tamara Rockroar. I am the LPN care manager for Treasure Coast Community Health. I have been an LPN in Indian River County for about 21 years, and I've been with Treasure Coast for the last 5. And I just wanted to share what our roles are as care managers and care coordinators within the FQHC. My role is centered on bridging gaps in care and ensuring our patients receive timely and coordinated and comprehensive services, especially those that have complex medical and social needs. I act as a bridge between our patients, our families, our providers, the specialists, the insurance carriers, and our community resources and social service organizations. And this includes coordinating the referrals, tracking the diagnostic testing, results, ensuring continuity of care across all multiple settings. I work closely with the providers to support in the clinical decision-making while helping the patients navigate, as we know, in a very overwhelming healthcare system. A large part of our role involves patient advocacy and education. We help the patients understand their care plans, remove the barriers to access, such as transportation, any insurance limitations, and connect them with the appropriate community resources and social service organizations that support their overall health and well-being. In an FQHC setting where many of our patients face socioeconomic challenges, this support is critical to improving the health outcomes. As the care manager, I assist in managing high-risk and chronic care populations, monitoring follow-ups, promoting preventative care, supporting our quality initiatives. I feel that my work has helped reduce our missed appointment rate, prevention and delay in care, improving patient engagement and satisfaction. Ultimately, our role plays an essential part in supporting our providers, strengthening our care teams, ensuring our patients receive compassionate and coordinated and equitable care, fulfilling the mission of the FQHC to serve our community with excellence. And I feel like without TCCH, many of these individuals would go without health care. Thank you.
Thank you, thank you. Appreciate that. Anything else?
Yes.
Hello, my name is George Lynch and I'm with Dynamic Life Recovery. And I just want to share something with the board here and with everybody at the hospital district. I come from a family ravaged by addiction. Every one of my immediate family members had an addiction or alcoholism problem. One person chose to get sober in my family. That one person changed the course of my family. Because that one person chose sobriety and used organizations similar to Thrive, my mother, who just recently passed away with 18 years of sobriety. I have a 16-year-old son, and he is studying business and economics. And he constantly questions me because he's smarter than me. That, hey, Dad, why don't you make more than $100,000 a year? Like, why aren't you out there doing, these amazing jobs with great pay? And I had to have a real conversation with my son. I've had more people die from addiction and alcohol-related deaths than I can count on both hands and both feet. And there's something to be said about giving back to our community, because I was a community taker for the longest time. And so I do what I do today because I want to give back. My family does what we do because we want to give back. And organizations like Thrive are leading in this community when it comes to recovery from substance use. And in other news, Ron DeSantis, our governor, just recently was in Brevard County and shared that the fentanyl overdose has been reduced in Florida by 42%. 42%. That's nearly cut in half. And that's due to communities coming together and working to solve this problem. So I would just ask that you guys continue to support the recovery process in Indian River County. Thank you.
Thank you. Thank you very much. Any other public comment? Great, you stand firm.
All right.
Right.